nuance. Why is all this coming about? So you're a 501c3 hospital. For the two of you who are municipal hospitals, you had a reason for applying for 501c3, probably having something to do with pension plans or 401k. Other hospitals are 501c3 because that's the way that they've set up the private not-for-profit. So if you're a 501c3, and the reason that these requirements apply to every 501c3 is that if you are a charitable organization, meaning then you were not going to pay the state, federal, local taxes, that in exchange for that you must do something to benefit the broad community. Not just your patients, not just your staff, but the broad community. That's in exchange, then you get tax-exempt donation, federal, state, local, and tax-free bonds. Kim was saying in the introduction, I was on the Franklin County. Franklin County, I mean, it's large. We have, 1.5 million people in there. And I was asked to serve on the the bond commission for hospitals. And when I was first doing, my role was from the county commissioners, let's make sure these hospitals are acting like not-for-profits. So I would start asking the question in the meeting, because they'd come in with all this financial information and market analysis they had done. And my one question to them, how are you benefiting the broader community? And they were irate. Oh, this isn't relevant. Who is she? What's she doing? And we got to the point where at the end of my tenure with them, they would come in and they would slam down their 990 tax forms on the table and say, it's in there. It's all in there. And then they started talking about, in the beginning, we're a not-for-profit hospital and what we're doing to benefit the community, and talk about that in relationship to their tax exemption. So from the county commissioner's standpoint, it was a complete turnaround. It just took, this was back in the 90s, though. It was really before hospitals started thinking of their role as more than just medical care and outside the hospitals that way. And you get donations, a lot of philanthropy. So if anyone comes to you and says, what's the value of your tax exemption? And we're seeing this, editors of newspaper, public policy leaders, state attorney general, congressmen, what's the value of your tax exempt? Just make sure that you include in there the value of donations that are given to your organization, because if you were not tax exempt, most people probably would choose another not-for-profit so that they can get their tax-exempt donation listed on their own tax form. So that's just a tidbit to do that. So here's the IRS Community Benefit Standard. This parallels what we're seeing right now. Remember what happened in 1965? Social Security Act, Medicare, and Medicaid came into being in 1965. And prior to that time, everyone equated community benefit with charity care. Hill-Burton Act, when hospitals after the war got money to build hospitals, it was all centered around hospitals taking care of defined communities, and that's how they got money to build these hospitals. Well, in 1965, when Medicare and Medicaid came into being, people started saying, well, there you go. Everybody's going to be insured. There is no reason for a hospital to be tax exempt any longer because no one will need charity care. Sound familiar today of what we're hearing today? And I say that's a real threat to not-for-profit hospitals because we're hearing the same rhetoric again in Congress. So everybody's going to have some form of insurance. And not-for-profits look a lot like for-profits, so there really is no need for tax exemption. And that's one of the big reasons now that hospitals are being scrutinized and saying, are you doing enough to benefit the broad community in exchange for your tax exemption? Well, the IRS in 1969 said, well, let's look at this. Are there ways that hospitals can help their communities in addition just to providing free care? So they came up with this one, promote the health of a class of persons broad enough to benefit the community as a whole. So this was the standard that the IRS came out with in 1969, and that's all they said. So they didn't define it. So for the past, 40 years now, people have started saying, well, wait a minute, what do they actually mean by that in terms of community benefit? What do we have to do to make sure and show that we are tax exempt? So here's what the IRS came out with and said, these are the categories of activities that you can do and quantify and tell people this is what you're doing in exchange for being tax exempt. I'm happy to say that these categories came about as a result of all the work that the Catholic Health Association did back in 1989. And so the IRS adopted it, and the IRS has been very good in the last number of years of also looking at what national organizations like Catholic Health Organization are putting forth that way. But these are the categories of community benefit. So we still have charity care. It's now called financial assistance in the IRS reg. So if you're revising your charity care policy, you might want to consider changing the title to financial assistance. People found it offending to say they're getting charity care, but if you say they're getting financial assistance, it sits with them a little better. Government sponsored, so Medicaid, anything that where a person has to be judged eligible for it based on income. So Medicaid, State Children's Health Insurance Program. In Ohio, we have what we call the HCAP program, which is based on income there. Medicare shortfalls and bad debt, in the eyes of the IRS, are not community benefit. This point was argued up and down every hall of Congress of whether Medicare shortfalls, and they said for-profits have bad debt, for-profits have Medicare shortfalls. They often have less in the Medicaid part of it. But then there are all these other programs and activities down here that qualify as community benefit. So the first category, community health improvement, these are the activities that a hospital does that if I came into your community and said, what does your hospital do to really help promote health in your community? These are the things I probably would hear. They do a health fair. They do, I can go to an educational session and hear about diabetes. They do screenings in the community. Sometimes they have a one-time clinic that comes in and I can go and get health care that way. So these are what we call kind of the health improvement activities. It also can involve, there's a subcategory in there that if your staff helps prospective patients become insured through Medicaid or other forms of insurance, that those costs of enrollment can be counted as community benefit. And so for a lot of hospitals, that's really a big cost. Some farm it out, others do it themselves. Again, the idea behind there is that then that patient can go out and access care in the community from other providers because they now have health insurance. Now, if you're just assessing them for your own financial assistance need, then it's not a community benefit because the organization will gain more from it than from the others, from the public in the broader community. Health professions education. So if you're doing any training for people in your community that are leading to a license or standard certification in the medical field, could be medical students, RT, PT, OT, social works, anything that will license them to practice in the healthcare field, and you are paying cost, and it's a cost to you to do it, and there is no obligation for them to work at your organization, then you can count those costs as a community benefit. So we always get the question, this is for the fiscal people in the room. Well, what if we have a student in accounting that's shadowing us? And so we've talked about this. We have a national group of hospitals who we run these sort of things back. And the answer comes back to unless it's specific to healthcare and they receive a specific license to practice accounting in healthcare, which I don't know if any really exist, then you would not count that. It's got to be licensed in the healthcare field that way. Subsidized health services, this is always, I think, a very unreported part, and for small hospitals in particular. And this is also a category that's difficult first go around to try and capture. But a subsidized health service in the eyes of the IRS is that you're running a clinical service line to meet an identified need in the community, and you're operating it at a very low margin or a loss. And that if you cease to run this service line, then the need would exist in the community. So you can count the losses after you subtract out other payments that are recognized, such you have to subtract out that are other accounting systems like Medicaid and bad debt that are accounted for in other parts of your tax form. So the easiest example is a burn unit, so some hospitals keep burn units ready. Big cost. You may not have a patient for 6 months and then all of a sudden you do, but if you failed to be set up to do that and incurring the cost, and you had a burn patient, then the need would exist in the community. Emergency departments, a big one that people count on their community benefit as subsidized health services. So if you think, and this is a question when I work with community benefit people, I say talk to your accounting person and ask them, there's actually a worksheet that you can use in the tax form to walk through to figure out. It's really a terrible process. I mean, it's very laborious first time around, and finance doesn't like to do it, but for hospitals, these are big categories, big numbers to report on losses that would count as community benefit. And this, you know, I still have so many hospitals say to me, but we do so much in charity care that if we calculated the cost of our tax exemption, we more than say we provide that much in charity care, financial assistance. So the question I always come back to them is, well, what if indeed some of the rhetoric we're hearing now is true, and that more people in your community will be insured through the exchange, or because I guess you didn't do Medicaid expansion here, but you did some kind of Iowa program. So you're actually hopefully going to see a big reduction in your charity care financial assistance. So the question is to keep your community benefit numbers up for people who are watching, public policy people, you really need to make sure you're capturing everything you do in these other categories in order to show that, and this is just the regulatory, that you're still a good not-for-profit, that you're fulfilling your tax exemption responsibility. So then a category on research. Research would be those processes that you're undertaking that generalize knowledge to society. So if you run, let's say you're running a quality improvement program in ICU, and you keep the findings of that just within your organization. In fact, you're doing it to make sure that your infection rates stay down. That's just a cost of doing business. But if you're running a program, say the same research project, and your purpose of that is really to look at this broad issue of ICUs and, I don't know, somebody's probably more clinical than me, but some type of research project that you can go on the speaking circuit, publish a paper, somehow thrust that knowledge back out into society, you can actually capture the cost of that project and report it under research as community benefit. Financial in-kind contributions. So one of my jobs in the hospital was whenever somebody in the community wanted something, they'd run up to me at a meeting with their hand out saying, well, you're the cash cow in the community. We need $100 for t-shirts for our Little League team. We need, they would come up to our board members at meetings and say, it would really be nice if, Riverside Methodist Hospital it just, it didn't stop on there. One of the real values now of having a community health needs assessment is to refine your criteria on what you will give donations or sponsorships to, and tie it specifically to the top 1, 2, or 3 needs of your community health needs assessment. It's so nice then for your board and your staff and for you to say, it's a nice project, but we really are trying to use our scarce resources to improve health status in the community, and we are looking for services in the community that respond to these needs that way. So the IRS is actually requesting now, or requiring any contribution you make, whether it's in kind or cash, that you have a letter that goes with it saying, Hague Memorial Hospital is delighted to make this contribution to improve the health status of our community. We recognize that this service that we are making a donation to will either improve access to care, improve population health, relieve governmental burden. There are 4 different areas that the IRS identifies, and that's your auditing thing. So if the IRS comes in and says to you, you made this cash donation, we see on your report, in your annual report that you have on your website, you made this cash donation, let me see your audit trail for it. So no longer I mean, you can still give money for the Little League t-shirts, but that's just a nice thing to do as a corporate citizen in your community. But it is not a community benefit. Community building activities. This is a very interesting one, and it's one that we're going to get in and talking about today when we talk about social determinants of health. So when the IRS started asking for documentation, and I know a couple of you don't file your 990, thus you don't have to do a Schedule H that the other two hospitals do. But it's still information that public policy people, editors of newspaper, we're finding this all over. So Sioux City or Sioux Center decides that they really want to look if the local hospital is deserving of their tax exemption because the city needs money for the police department. So who are they going to go after? They're going to go after the hospital that way. So even if you don't have to file a Schedule H, then we recommend that you look at this, the definitions in an IRS and somehow capture that as part of the story that you're telling. So the IRS said, you know, we think hospitals provide a lot of stuff that they're just dumping into community benefit that we think really has no relationship to improving the health status of people in the community. So they came up with this category called community building activities, and these are the activities that impact health, but they're further upstream. They have to do with workforce, green space, coalition building. And the IRS was afraid hospitals were just going to dump everything into community benefits. So they said, well, let's create this category and kind of look at what hospitals are doing. And then over the years, we'll assess it again. They finally, in the last go-around of the 2013 Schedule H, now have said some community building activities can be moved over into the community benefit if you can show the direct relationship to health, some kind of scientific thing. So how far that goes in their logic, we don't know, but let's look at this logic change. So scientific evidence, research shows that people who get better education, get better jobs, they make more money, and research shows that they have better health care and their health status is better. So in the past, if we were working with developing jobs for very vulnerable populations in our community, we had to put those projects under community building. Now the question is, well, couldn't they go under community benefit because of scientific research that shows this link to this far upstream social determinant of health and to the actual physical health and mental health in their community. So we're testing the waters with community benefit, and there's actually, for those of you, I know one hospital, how many of you use a software called Sabisa? Just one hospital? There's two hospitals. Are you both Avera hospital? Yeah. There's software out that actually helps hospitals capture what they do in community benefit. And the Catholic Health Association, under this community health improvement, added a new subcategory that will capture these activities that you now want to move over to community benefit. So they're working with the IRS to say, see the link, don't you think that it will count that way? So then the other was community benefit operations. So it's any time, any expense that your organization spends on doing your needs assessment, doing your implementation strategy, sitting in this meeting today, paying for the Sabisa software, paying for some other data that you want. Any operations that your hospital does, in particular staff cost, should and can be reported under community benefit operation. Again, often a unreported piece on there. Grant writing that your staff does to try and bring grants in for community benefit. So any questions on this community benefit? The IRS says that a community benefit activity must address an identified community need. So if you haven't identified a community need, then you can't say that it's a community benefit. So again, another value add of the needs assessment because you have it right there on the identifying the need. This may be muddying the waters, but the IRS says there are actually two other ways that you can identify need. And one is if a governmental organization, so you come and say, look, we're going to do this immunization clinic, will you partner with us on that? That in the IRS mind is enough to say it's relieving governmental burden by the hospital participating. And the other is if a group comes to you, let's say you have a new immigrant group who comes into your community and they say, we really need, that's another way, as long as you document it, I mean, put it in writing somewhere, put it in a file, that this group came to you, you know they're a vulnerable population in your community, and they have presented this need to you. So you can do the formal needs assessment, you can be asked by a community group, organization, or a governmental piece on that. So there are 3 different ways, which gives you a little more broader on there. So you have to identify a need. You have to be able to say, in addition, that it does one of 4 things. It relieves governmental burden. It improves population health. It contributes to the education, the research piece, which are these other 2 categories. And it opens up access to care. So that's why I was suggesting in this letter that you write with the donations and sponsorship that you say it addresses X community need that we've identified, and pick one of the other 4 objectives on there. And then you've got your whole audit. So here's what was happening before, and this certainly was the case in my organization. We were doing stuff all over, and when I would ask somebody, why are we doing this program, they'd say, we always have. You know, we have done this program for 20 years. I gave the example of, well, our board member asked, or somebody asked the CEO, you know, can't you please, we really need some money that way. So Congress, and you know, we attribute a lot of this to your congressman, Senator Grassley, because he really got this whole thing started on here. They started saying, in fact, Senator Grassley, I love this, he would have looked at this and said, this is exactly what I'm seeing. I cannot tell a hospital's community benefit program. He said, to me it looks like it's like comparing apples to tractors. That's what he said on the floor of Congress. So he said, I don't know what these hospitals are doing. He had first looked at other not-for-profits, the Smithsonian, the American Red Cross, and then these hospitals, you know, we're so easy to get our arms around. Big bucks, we take a lot of land, we use a lot of local resources. So what we have seen happen then is in the Patient Protection and Affordable Care Act and health care reform that we saw 4 different tax exemption requirements that came out of that. And this is all goes back to what the purpose is of a 501c3. So the question was, are you deserving tax exemption? So they came up with 4 different requirements. The rules to these are not yet final. We're waiting for them. Hopefully they'll be out this year. The first one is to limit patient charges so that you cannot charge people more than what you're charging to your average of your Medicare or insurance patients. This came about, do you remember, what was his name, Moore, who went after the tobacco companies? Michael Moore. So Michael Moore had a situation come up when an uninsured patient said to him, I went to a hospital and I don't have insurance, and they told me my procedure was going to cost me $100, and that's what my bill was. My friend who has insurance went to the hospital and had the same procedure, and the contractual rate between the insurance company and the hospital was $60. So they had to pay $60, not $100. And so he said, this is crazy. Why are hospitals charging full charges to people who are uninsured when people who are insured are actually being charged less because of the contractual rate? So this is the reason that this limit patient charges came about, listing that you can, you have to limit to people eligible for financial assistance. You have to have the criteria in place. The other is to limit collection practices. You know, you hear stories, see them all the time. People go into medical bankruptcy. They lose their house and that. These hospitals, they have so much money anyway. They're rich, and here they are running people into bankruptcy. So they put this provision in that it prohibits extraordinary collection practices before determining if an individual is eligible for financial assistance. You have to adopt a financial assistance policy. So if you have not done so for a while, the recommendation is pull it out, dust it off, change the name from charity care to financial assistance, and do your best to develop the criteria to rule in people who are truly eligible. Otherwise, they're going to end up in the bad debt. You're going to spend a lot of money on the debt collection practice. And put as many caveats as you in. The IRS says if it's in your financial assistance policy, in the criteria, they would be eligible. So we get a call from some hospitals after Haiti, that when they had the, was the earthquake, wasn't it, or in Haiti? And they said a number of our docs went over on a medical mission, and they want to bring back patients to have surgery for injuries. Can we count that as financial assistance? So we talked about it on a national level, and the question back to them is, does your financial assistance policy allow you to treat people from out of the country? And if it doesn't, then they would not be eligible for your financial assistance. So you can go ahead and treat them, but the cost to treat them would not be countable as financial assistance. I mean, some hospitals have it very tight that they'll only, people are only eligible in certain zip codes, or people eligible only in that county are eligible for full discounted, and sliding fee scale applies to other. So it just depends on what your local situation requires. But the point of this is to make sure that if I read your financial assistance policy, and most hospitals now are putting them online, maybe kind of a layman version of it, that I will know if I'm eligible and know what your criteria is for financial assistance. They need to be very explicit, and then board approved, so that the board knows that this is the policy for the hospital. So these are three, and then the fourth one, which is what we're really talking today, is this one about community health needs assessment and implementation strategies. So as I mentioned, that these 4 tax exemption requirements in the Affordable Care Act, the IRS rules are not out, although bless his heart, Senator Grassley just wrote a letter to the IRS in April saying, where are they? Why aren't they out yet? You know, my Iowa hospitals are trying to, in good faith, implement these, and you don't have them out. So this is what Treasury has put out, the IRS and Treasury. So I put the URL on all of these. But this first regulations covers the financial assistance emergency medical care, and the second one covers community needs assessment and implementation strategies. So early this year, then in February, the IRS came out and said hospitals can rely on these 2 regulations as guidance on how to implement healthcare reform until the final regulations come out. What they also then put out and released this one, proposed procedures to correct and disclose failures. When this first came about, I don't know how many hospitals said, I'm going to pay the $50,000 fine for not doing a community health needs assessment. It will cost me more to do a community health needs assessment. Well, I think the IRS heard a lot of them say that, because they put this out and said, if you are willful in not following this, we will come after your tax exemption. It's very strong language in there. So again, this regulatory strength, I guess, in this requirement to do a community health needs assessment. So I'm going to move into the definitions and what the specific requirements are for that. The IRS gave a very simple definition of what a community health needs assessment. It's just an assessment of the health needs of the community. You know, originally they just said needs, and people said needs. Well, my community needs so much, so they came back and it's just the health needs. The Catholic Health Association and VHA, these 2 national organizations, tried to come up with a more descriptive term of what they think a community health needs assessment is. So the specific requirement is that at least once every 3 years, every 501c3 hospital conduct a community health needs assessment and develop a written implementation strategy, and both need to be approved by a hospital governing board. Last year I was in Park City, Utah, talking to boards of trustees west of the Mississippi. And they were talking about regulatory requirements of the Affordable Care Act, and I was talking about this, and they said they had never heard about it. And then one said, I think that's that thing we adopted at the, but they didn't take it seriously. So once they heard more about the regulations, and in particular some of the tax-exempt implications of all of it, they really took it a lot more. And then they had a group discussion, so should we really be asking our hospital administrator? And it was, what were the needs, who did you include in it, and go through all of the different requirements of that. So we're seeing different responses of the boards. Boards of trustees are also seeing from their professional groups the responsibility that's hanging on their shoulders to make sure that they as a not-for-profit are acting like a not-for-profit and looking specifically at some of these requirements. So they're hearing that from their other colleagues and from some of their professional pieces. So this is kind of a wordy slide, but this is what the IRS says must be included in the assessment, that you can actually base it on information collected by other people. So I know most of you did surveys, and I'd like to talk about that when we get into this piece. But you can actually use information that's collected by others. So when you form this community team or piece on collaboration, who has what other information that gives you this picture of it? We're finding that a lot of the co-ops in different communities have really had lots of information that they're looking at. So, and it could be public health agency, it could be United Way, senior citizens group, any other not-for-profit. You know, all not-for-profits are required to assess the needs of their community. If you'll probably start seeing a little different language come out about the United Ways. I did some work with, what was it? It wasn't the Boy Scout. Might have been United Way, but they were, oh no, it was the YMCA of the USA, because people were knocking on their doors saying, you know, it's really expensive to try and come here. What are you doing to improve the health status of people in your community? So they said, what are you talking about? We've never had anybody ask that question before. So every not-for-profit is required to do a community health needs assessment. It's not called that, it's not in the regulations, but the assumption is they're spending their resources that they're not paying in taxes to benefit the community under the function that they're doing. So we're seeing across the United States in the YMCA a lot of linkage now between hospitals and YMCAs for obesity programs, to provide scholarships. So again, bless his heart, Senator Grassley, he's looking at all not-for-profits, not just hospitals. The next major group that Congress will be looking at are universities, education facilities, because they take a tremendous amount of land mass in which they're not paying property taxes on that. So you have to include input from members of the medically underserved, low-income, or minority populations in your community, or at least individuals or organizations who are representing the interest of that. So when I talk about the requirements in your report, the same information needs to be spit back out. Who were the organization, the people, what groups were they? The original rules that said you had to identify them by name and when you talked to them, and people came back and said that violates HIPAA if they also happen to be patients. So you just have to make sure that you include that. Have to include input from the public health department, and you must include written input from previous assessments. So you all have your CHNA on your website. So if you get any comments, written comments back from people in the community, and some organizations are putting a survey, you know, kind of like a monkey survey after their community health needs assessment, saying, do you have comments? Would you like to participate in the next round? Kind of that feedback section, and that must then be included in this next go-around of needs assessment. You can conduct it in collaboration with others. In fact, it's encouraged. Don't reinvent the wheel. Data is data, you know, especially secondary data. There's no reason for every hospital to be pulling the same data. Each hospital has to do a separate assessment report, which you've all done. You can do a joint report. This is new, the IRS, when they came out. For example, in Indianapolis, there's a hospital system, and they have 6 hospitals, and they're all within the same metropolitan area. They were trying to do 6 different ones. The data was the same. Their action plan was the same. So the IRS says as long as you define your community the same, you can do a joint community health needs assessment. In the report, though, you have to identify that Hague Memorial will do this and Sioux Center will do this, and so that I can read them as a layperson and know exactly what each hospital is going to do. But otherwise, each hospital has to have their own separate assessment report. And it's considered complete when it's made and conspicuously publicly available, which you've all done on your website. So if you're starting your process now to do it again, you can actually start the process and do as much work as you want now. You can actually post something on your website labeling it draft, And the clock doesn't start until you actually take the word draft off and make it conspicuously publicly available. So this bugaboo about having to do the same, in the same tax year, your implementation strategy and your community health needs assessment, you can go ahead and work on your community health needs assessment and then post it in the year that you're going to have your implementation strategy done. So that was at least a little leeway, and that's what the IRS was thinking, that a process would kind of be continuous and wouldn't have to be like this first go around, start and then stop. And you have to keep on your website, in your case, the previous 2 years' reports, so that eventually down the road you'll have 3 years' report on your website. And then when you put, say, the fourth one on, you can take off the first one. So eventually you're going to have 3 on there. So this is the actual requirements that are required in the report from the IRS. For those of you who don't have to file a 990, it's still a requirement for you to have this community health needs assessment report. So this is what you actually have on. So your description of your community, you all had really nice circles. It was easy for me to figure out where in the state you saw. There's overlap, but you're also kind of distinct in saying this is the group, this is the population we feel responsible for improving the broad health of the community. A description of the process, methods used, description of input from persons, who, you know, what time period they collected, names of organizations, target groups represented, a prioritized description of significant health needs identified, and in the implementation strategy, actually how the needs will be. There was a lot of discussion on that, but they said, nope, for the purpose of the report, it's just a description of the prioritized needs. And a description of potential measures and resources to address needs. This has always been a little confusing. Well, what do they mean by this? So if you go online and just go to a hospital and put in community health needs assessment, hopefully it'll pop up. It did with all of yours. That's what I did on there. By the way, 3 of you have it under the about, and 1 of you have it under patient rights. So the one that had it under patient rights, it took me a little longer to find it because I had to do more than one or two clicks. If it was under about, I went right to about, and there it was. So when the IRS came back and put the word conspicuous in, it was that hospitals, they were saying, but it's on there, but you know, you couldn't find it, so it wasn't any good for the general population to find on there. So the potential measures and resources might be other organizations you're going to work with, maybe particular clinical pieces of your organization, certain funding that you might be putting on there. They're really looking, did you look in the community for assets and other resources? So you would want to include those in there too. So you have to make it available. Most people are putting it on their website and upon request. So if I walk into your organization and say I would like a copy of your most recent community health needs assessment, you have to make it available to me. And it didn't say in there if I want to walk out the door with it if you charge me for copying or not, but I have to be able to access it and request it. So I could call your hospital operator and say, you know, hi, I'm Patsy Matheny. I would like to receive a copy of your most recent community health needs assessment. So hopefully they know what I'm asking. You know, I do that sometimes. I'll call a hospital and say, I'd like to speak to your person responsible for community benefit. And they'll say, you know who they've used? They don't know, because often people don't have that title. So you guess who they usually refer me to? Marketing. I'm digressing here, but I think it's an important piece. Back when we first started in community benefit, if we had been having this meeting today, every person in here would have been from marketing. That's it. And then we started meeting and talking to finance people who all of a sudden, I remember vividly in Kansas City, there were all the Kansas hospital CFOs in there, and they had the blankest look on their face, and I thought, I must not be saying this right. So I went up to one gentleman at the break and said, why are you all looking at me like this? And he said, we had no clue even why we were coming to this meeting, but the CEO, administrator, walked past my door and threw this thing down, which was the Schedule H 990, and said, do something with it, do something with it. So the finance person said, We didn't know even what community benefit was. So now we have lots of finance people in the room today. If we took a survey once of hospitals, we had 65 hospitals in the room, and we took a survey of where they fell in the organization, and there were 43 different titles for them. We're seeing a lot in compliance now, risk management, never seen before. Finance, out of the administrator, CEO's office on there. It's just all over the board, which is good. It just means there's a lot of education internally. So that's why I mentioned about the hospital operator, whoever answers your phone. Where would they send me? I mean, who would they refer me to? If I asked for a copy of the report, what would they do with me? So it's just, kind of the educational, internal as well as external in telling your story. I'll tell you, people are pulling these reports off websites from all over the United States. GuideStar.com, they're pulling 990s, state attorney generals, anyone who's looking for money, and they're looking for it from hospitals. Public health departments, There's a movement afoot in the United States that, because of this emphasis now on public health, and that public health doesn't have any money, that since hospitals won't have as many charity care costs, that money they would have spent in charity care ought to go to fund their public health agency in the time. And those in the hospital system are saying, it doesn't work that way. I mean, we also, in the Affordable Care Act, took reductions. We're taking reductions in other cost payments. So we're not going to have this excess money sitting around for hospitals to fund public health. So the message is, let's get hospitals and public health to work together and really look a little more upstream on the prevention and health promotion side, which will help with some of the other clinical pieces of the new Medicare payment and a couple of other, the value-based, and say let's work together to do the prevention and really improve health before people come into the hospital. This was a message years ago, and hospital administrators would say, I need my beds full. I want the patients. Where we say now the hospital of the future will have not very many beds. Going to have a lot of outpatient, going to have community-based. We're just in that gap now of trying to make the change over, and that's why people who think they can get rid of Obamacare can go back to the old way of delivering the healthcare system. But it was such a complex bill that it was like dominoes and chain reactions, and you can't just delete one piece without upsetting the apple cart on the other, so it gets very convoluted in the eyes of the public to even try and understand it, which is a tremendous messaging problem for hospitals to deal with. So, written plan, implementation strategy. You have to say which needs you're going to address. And in the beginning, some hospitals who jumped on the bandwagon and did this early, they came up with lists of 100 needs in the community. I mean, you can do that in your communities. You will find 100 needs. And they were saying, do we have to respond to each of them? So the IRS came back in subsequent releases of their proposed rules, and it's now the significant health needs. We tend to see 3 to 5 health needs. Some hospitals might do 10, one might do 2, but 3 to 5 seems like the average of what we're seeing. I mean, you can't do it all, so what are you really going to spend your precious resources on? But you also then need to, in your implementation strategy, say, we also identified these significant health needs, but we're not going to address them because. We're not going to address them because it's not our area of expertise. We're not going to address them because some other organization in the community. We're not going to address them because there simply aren't enough resources and we really need to focus on these high significant needs that we found. We're not going to address them because there's no will in our community to do it. If my community has to look at infant mortality one more time, no one will come to any meeting on it. So even if it rises up again, there is just no will in these next few years to address that. So what makes sense? What's the best use of your resources? Describe the actions you intend to take, the anticipated impact of these actions, and your plan to evaluate it. Absolutely crucial, because those of you who need to file a 990 every year need to say in your core form 990, the progress made towards the actions that you listed in your implementation strategy. There are people in Congress who are looking at these 990s and I'll show you a picture of the 990, the total value of your community benefit, and you'll say, we spent $500,000 in community benefit. And the question is, so what? You spent $500,000. What did you get for that? What were you trying to address? What health need of the broad community, and did you impact it? So that's the next question that's coming down the pipe. We've talked it must be completed in the same tax year, each hospital a separate report, and you must attach your implementation strategy either to your core form 990 or give the website where it can be accessed. So for those of you who don't file the 990, as a concerned community citizen or a community activist or someone from a public policy agency looking for money, I'm going to call you and say, where's your implementation strategy? So again, on the website is the best place to put it. Here's just an example. I've looked at a number of them. I think the implementation strategy should be a standalone document. You know, if I look at a community health needs assessment report, some of them are 6 pages and some of them are 100 pages. So the question is, how much supporting data do I need to put on there? The IRS is simply the guidance they've given is your full report must be conspicuously available. Some hospitals were just posting a 1-page executive summary. So others are putting all the data on there. So it's all there. They call that comprehensive. But on the implementation strategy, I may just want to read that. So in the executive summary, I want to know how you even did your community health needs assessment. I don't want to have to read that report. I want to know your strategy, how the plan was developed. Tell me again the target populations, your significant health needs, how your priorities were chosen, description of what you'll do, action plans, next step, needs not being addressed, and I really want to know when you took this to your board, because I might run into one of your board members at the next chamber meeting. So I want to sit by that person and talk to them about the hospital's role in the community. So I'm playing devil's advocate here because I don't work for one of the community activist groups on the East Coast and the West Coast, but they do exist and that's exactly what they're doing. So we've talked about these two things, the annual filing with the 990, and also I mentioned that there are 2 other ways that needs can be identified. Now the IRS did say in your implementation strategy you can put all the actions that you're doing to address identified needs. So it's not just what you identified from your CHNA, but from the other 2 ways too, that people who came to you or request from a governmental not-for-profit agency to do it. People were afraid they'd had to have an implementation strategy just addressing the CHNA needs and then have this other plan over there. We were seeing plans all over. Another plan to address other needs that they were doing. But the IRS says, nope, you can put them all into one plan. Implementation strategy, most people are calling it their community benefit plan. If you do that, I suggest you call it your implementation strategy / community benefit plan, so that if somebody's looking for the word implementation strategy, it's right there. If they see community benefit plan, they might not think that they might be the same piece on that. We get asked the question all the time, what if we have this project we've been doing in the community and the need didn't surface as a significant need? Do we need to quit doing that and redirect our resources? And the responses come back, if you quit doing that, would the need surface again? Is the reason that you're doing that is why the need isn't showing up? And if that's true, in your implementation strategy, you should be listing that as one of your primary activities that you're going to do. And talk about the need and the fact that it didn't rise to the surface, but that's because you've been addressing it all the way along. For those of you who haven't seen an IRS Schedule H, it's grown a little bit. It's actually 9 pages now. This is the one that came out. It's 2013, release 2013, which is the one in effect for tax year 2013 filings. They will be releasing it again. They said it may look, the 990 probably will look significantly different, which is one of the reasons that they haven't released the final rules on that. and that possibly Schedule H will be too. But these are all the different pieces of it. Facility information was the new section added about 2 years ago, which has all the questions about community health needs assessment. So for the 2 hospitals in here who don't file a Schedule H, I suggest that you download a copy of it and just look at the questions so that you're prepared if anybody comes asking, or in particular what public policy leaders are looking for in terms of that. But just a thought too, Teresa mentioned telling your story. There's a part 6 of this which is kind of open-ended, and there's a question on here, what else do you do that benefits the community? Put everything down there, anything you can think of. Things that we would call that you're a good corporate citizen, but you're not quantifying. Anything on here that that you just want to talk about your board being good community, you know, other pieces on that, because a lot of people are developing their whole story about what they pull off the Schedule H on the supplemental. So this is what it looks like. These are all questions about your community health needs assessment, your financial assistance policy, the billings and collection. That was the new section that was added. And this is the first part of Schedule H. So I've been talking about this number right down here, which is the total quantified community benefit number. So this number right down here is what people are saying, asking the so what question. So you've taken all those categories, financial assistance, the Medicaid and other financial categories, and these other 7 categories, and you said this is what we're providing. So this is where they're starting to ask the so what question. I mean, some hospitals here have millions and millions of dollars. One of the big changes in this Schedule H, and I don't know how much it might impact you, but for those of you who do the reporting, remember in the past, the IRS said if you get a grant to do a particular community benefit, you don't need to offset the expenses of your project with the grant money. So if you were running a immunization clinic and it cost you $500 and you got a grant from the state health department of $400, you could still report as expenses the whole $500 to run that immunization clinic. Well, the IRS, because they said they didn't want to discourage hospitals from looking at from going out and seeking other funds. Well, the IRS came back this year and changed all that. I mean, they flip-flopped it, saying that you must now offset the expenses by the amount of the grant. So if your immunization clinic was $500, you got $400 from the state, you can only report $100 for it. The significance came with the academic medical centers under their research. They were doing millions and millions in research, NIH grants. They didn't have to offset the cost of that. Now all of a sudden, the academic medical centers in their latest tax form are showing a real dip in their community benefit, and it has to do with the grant dollars on there. This is the community building activities. There are these 8 categories on here. Again, social determinants of health. And again, I mentioned Part 6. For those of you who are responsible for doing that, you know, just put everything down there and ask people who are involved, other staff, if they can think of things to put in here. It just tells the whole story. So here's one other thing that seemed to slip past a lot of hospitals, but as part of the Accountable Care Act, they asked the IRS Treasury Department to report the community benefit activities of every 501c3 hospital at least once every 3 years. And so they have asked that for charity care, bad debt expense, and the means-tested government programs be reported for all hospitals, all not-for-profits. And for those that are private tax exempt, which the 2 non-municipal in here are, your community benefit activities. So Congress didn't get the report, so Senator Grassley wrote a letter in April to the IRS and said, where is it? We haven't gotten a report. And why aren't your final rules out yet? And why haven't you developed a memorandum with HHS to make sure all of this happens? So the IRS responded back to him and said, we are in the process. We have actually reviewed every 501c3 hospital in the United States. And they answered a question that we weren't sure how that they were doing it. So because we thought all the municipal hospitals said, well, if we don't file a Schedule H, what's the IRS going to look at? Because we thought that's where they were going to pull a lot of information. So they actually came back and said they are pulling this information from the Statistics of Income, SOI data, and the CMS cost report data. Anyway, this is free, and I think the process that you all used last time was based somewhat on the MAP process, which is more of the public health. The point is, when we were putting together the assessing and addressing community health for Catholic Health, I reviewed every book out there, process on it, and they're all about the same. The steps are the same. One may have 5 and another may have 8, but it's still the same process. Prepare and plan, determine the purpose and scope. So what I mean by this is, what are you going to use it for? What's the value add to the organization? And how far upstream are you going to go? Are you only going to look at health needs, or are you also going to look at more of the social determinants of health? And you have to make that decision up front, because that will then feed into actually identifying the data and pulling the data together that way. I think that people in hospitals, unless, if you might find a physician. I have found physicians in hospitals who love to work with data and who were really into statistics, and they like to help analyze data. So in my organization, I found a couple physicians, and they participated on our process on it. But some of this is needs to be very well done on how you defined your criteria for deciding what the priorities would be. Again, this question of where you're going to spend your resources. And then putting it all together, documenting and communicating results. So let's talk about value add to the organization. Meet regulatory requirements, absolutely. It's not the main reason, but it's probably, I hope that from the beginning part of the regulatory that I talked to you about was the reason that the regulations came into being in the first place. And that's because people don't think that not-for-profit hospitals are acting like a not-for-profit and thus don't deserve tax exemption. And if you lost your tax exemption, I don't know, does anybody in here know what the value of your hospital tax exemption would be? It's a lot. So it guides the use of scarce resources, supports grant writing or fund development. If you've ever had to write a grant, digging around for supporting data of why you want to do this activity is a real bear. It takes a lot of time. So if you know that you're going to do grant writing or fund development, in the beginning, remember you go back, what's the purpose and scope of doing a community health needs assessment? We want to make sure that the data we get out of our assessment will help us in grant writing. And it's not just grant writing for community benefit programs, it may be for your clinical programs also throughout the organization. We've talked about the criteria for donations and sponsorships. Promotes collaboration with other community organizations. Again, we just can't say it enough, no reason to do it alone. I know hospitals are very competitive from a clinical standpoint. In my personal opinion, I don't see any reason for hospitals to be competitive in community benefit. They're not fundraisers, revenue producers, generally. They're expenses to the organization. So if you have any overlap between the 4 of you in here, the more that you can collaborate on that, even on the initiatives afterwards. You all have obesity as one of the top priorities on there. So you talked about doing some kind of obesity. It's just the collaboration. What are the evidence-based programs that have been done in the United States on obesity? Somebody research it, find those programs, let everybody know how you're going to work on it. There's no reason for all 4 hospitals to have to do that research or collect all the data or do an analysis of all the data. So there are real reasons to promote collaborations. And that's not just between the hospitals, but it's any organization. It can be the schools, the business, the banks, other people in your organization, community to come together and collaborate on this. This is where we have been trying to move for 20 years with community benefit, and we're finally getting there because of the promotion in the Affordable Care Act on value-based purchasing of hospitals and accountable care organizations and this cost and risk sharing. It's do spend your scarce resources on programs that improve the health status and additionally improve the hospital's clinical and financial operations. We have tried to get to this for years. There was never any payment incentive to do it, and now we think there is. So, for example, on the secondary community data, I think the health department was able to give you lots of secondary data. Again, if you look at, these are all pretty clinically oriented. We've got cancer and diabetes, exercise, nutrition, weight. Find out all of the secondary data indicators that are available within Sioux County that you can find. Again, go back to the original purpose for doing this, and what's the scope? How far upstream are you going to go? Do you want to look at education in the community and really look at this way upstream education, better jobs, more income, health insurance, better access to care, better health? Or are you just going to focus on right now treating the people as they come in? So know how far upstream you're willing to go. Think about health delivery in your community, and are you going to do the accountable care organizations? Who are you going to collaborate with? Are there health insurance programs that also want to participate? They have a tremendous amount of data, by the way, that can be fed into your community health needs assessment. So these are more of the traditional health category. By the way, this slide is from, there is a really cool tool out there called the Healthy Communities Institute. It was put together by some professors out of Berkeley. And they can do it countywide, they can also do it statewide, but they take every indicator that they are aware of that would impact your county, and they measure it for you, and they put it in here, and then they measure it based on national benchmarks where your county stands on that. So I like this because for some of the hospitals that use this, when they take them to, say, community groups, community forum, it's so easy for them to say teens who are overweight or obese grades 7 through 20 in Bucks County, this happens to be in Pennsylvania, they're doing really well with that. They're in the green, so why would we spend our resources? Or in our obesity program, let's don't look at overweight or obese grades 7 through 12. A waste of our resources to do that. Instead, they might want to look a little bit more like grades K through 6. But what I like about this is, and it doesn't have to be this resource, although it's web-based, that's real-time data, they keep it updated all the time, and is that it presents the picture, so it makes it easy. So if you're looking at the data, you can say, in the community disparities, you can actually find out and map this data so that you would say, if we're going to do an obesity initiative in our service area, which part of the service area should we really direct our resources to? Is it the northeast quadrant? Is it right central? Is it southeast? Because you don't want to start with build a new playground with another community group in the southeast if the K through 5 obese kids, when you map it out, is up in the northeast. So it's just strategic looking at the data that way. And of course, collecting primary community data. There are a number of ways to collect data. This one I think is fun. This is one, so for example, Harvard used it. When they were building their campus, they had somebody sit there and watch where kids cut through to get to class, and that's where they built the sidewalks. Because they knew if they built the sidewalks, the kids were going to probably cut through, and it was a waste of money on their part. So the behavior mapping is kind of fun. You'll see people sitting at corners and lights and doing check marks and things like that. When hospitals do market analysis to figure out how to increase share to the hospital, that is one type of analysis, market survey analysis. In my mind, it's different from what a community health needs assessment survey is. So you may want to ask some questions to get at this access to care issue, but it needs to just be a piece of this broader assessment. Otherwise, you're never going to get at the question, again, looking at obesity, why are the kids K through 5 obese? And what you might have found out in a focus group in a neighborhood is, well, they can't walk to school, it's too dangerous. There are no no sidewalks. And so that's a different type of intervention than looking at just providing a school nurse or going in a more traditional way that way, or making sure that you have a childhood obesity program that you're going to add it to one of your clinical service lines that way. I think you miss a lot of what really impacts the health in your community if you just ask the questions that you would normally ask in a market analysis survey. So I just throw out food for thought. In your second go-around, you may want to work with the health department more on collecting secondary data. They certainly said they work with the state health department. Look at other resources to do that, and maybe have a town hall meeting in your community and hold it at the local meeting place, wherever that might be. Maybe not at the hospital or that. And it's the same thing with your employees. I'm guessing most of them live in the community, so they're actually part of the community. So perhaps just, have department heads run some focus groups of their neighborhoods, and that way you get the culture starting to build in the organization. So I just throw that out. If you still want to do surveys, see if you can trend and benchmark and build on it. Otherwise, it's really hard to answer the question, did we move the needle or not? But here's something else I suggest, and this is what I said we're evolving to. I think a community benefit program, activity, service, whatever we call it, should benefit, improve the health status of people in the community, and help the organization. Otherwise, you're just spending a lot of time and resources without putting the two together. So, for example, talking within your organization, who is the data person? So, where are the red flags? Who are the target populations that you're trying to really make sure don't readmit within 30 days? 2/3 of readmissions, they say, are avoidable, and the vulnerable populations, again, vulnerable in the terms of our definition, are people that have less access to health care than others, and it can be for a variety of reasons. Often it's because of financial, so we think of indigent people. It can be language, it can be disabilities, it just can be culture, that sort of thing. So of the vulnerable populations, they say that it's the greatest percentage of readmissions to the hospital are by people who would fall in this. So where's the data within your organization and saying, who do we want to keep out from being readmitted, and then what kind of community benefit programs can we do out there in the community? So for example, I used to run a national diabetes program, and we always looked at cost of diabetes complications on the inpatient unit. So the question was, we can deal with the patients when they come in, but they're expensive. They overstay, we get paid per capita. What kind of programs can we do out in the community to really help people who have diabetes in the community, whether they're going to become patients of my hospital or not? Probably in your community, they will become. So can we work with local churches and start some parish nurse programs, or can we have a clinician go in and do foot checks after service to see if they have sores on the bottom of their feet? Can we have the pastor in the pulpit talk about diabetes and what to do, kind of a health promotion piece on that? Can we work with the local pharmacist to have people with diabetes come in and get diabetes education? So do you see where I'm going with this? It's taking what you would normally think of as a community benefit activity, but targeting it towards the populations that are also causing you headaches on the inpatient side. Emergency department data. I know a good example of this. In my emergency department, you mentioned that I was in this medical social service and discharge planning department, and they didn't have social workers in the emergency room. This was a large hospital. We had 1,092 beds, so it was very large, no social workers in there. So we set up a 24-hour, 7 days. So we started looking at the data, and we found out there were a number of accidents, kids coming into the emergency room from car accidents, from one intersection close to the school. So we worked with the city on getting a stoplight put up. Really decreased the amount of accidents. It was such a simple solution. But it wasn't a clinical solution at all. It was really looking at what are we seeing in the community and what are we seeing in the hospital and trying to come up with a good solution for that. Other clinical quality indicators, what are you trying to do with JCO or HEDIS? Just what are the red flags? What are you really working on? What are your clinical goals and your financial goals? Ambulatory care sensitive conditions. So good outpatient care can potentially reduce it. So here are examples of the ambulatory care sensitive conditions. So remember that statement back that most readmissions are caused by vulnerable populations and also account for a lot of the healthcare. Just look at all of these. I mean, you could just look at any of these going down and think of different programs that you could do in the community. Obesity, you could fall within a lot of those. Adult asthma, we've got a lot of hospitals working with high polluters in their community to try and reduce the amount of pollutants in the air, let alone the hospital itself trying to reduce it, because one hospital is a major polluter on that. There's a hospital, Gunderson in Wisconsin, and they're actually taking the gases that are coming off of both the landfill and off of the local brewery, piping it to the hospital, and then giving it back out for clean energy in the community to try and reduce the pollution. So do you see the direction I'm going with all of this? So this is what healthcare reform was all about. Instead of being paid for the amount of procedures that we do and keeping our beds full, the impetus and encouragement upon hospitals now is to keep people out of the hospital and to collaborate with others in the cost sharing to see that it's done. And the biggest cost drivers are the social determinants of health, such as lack of physical activity, poor nutrition, and other environmental factors. So we have found, for example, in the obesity program, that there is this idea out there that if a physician who sees an overweight patient and he or she, the physician, take out the prescription pad and write on there, I am prescribing exercise for you 3 days a week, that patient will try and exercise 3 days a week. Because they wrote it down, they gave them a prescription to the patient, it looks like a medical thing to do. Versus physicians who don't even talk about it. So maybe one of your initiatives on obesity is just to get all the physicians together and say, can we set up some protocol for how and resources that you can refer your patients to who are overweight. So it's just 1,000 different ways to address that. So Dan, will you read the black question to me?
Why is Jason in the hospital?
Well, Jason's in the hospital because he has a bad infection in his leg.
But why does he have an infection?
Well, he has a cut on his leg and it got infected.
But why does he have a cut on his leg?
He was playing in a junkyard next to his apartment building and fell on some sharp, jagged steel there.
But why was he playing in a junkyard?
His neighborhood's run down, kids play there, and there's no one to supervise them.
But why does he live in that neighborhood?
Well, his parents can't afford a nicer place to live.
But why can't his parents afford a nicer place to live?
His dad is unemployed and his mom is sick.
So why is his dad unemployed?
Because he doesn't have much education and he can't find a job.
But why?
So, as the hospital, what do we focus on? The infection in the leg when Jason comes into the hospital. And he got it because he cut it playing in the junkyard. So what do we hear around the nurse's station? Somebody ought to talk to those kids about not playing out there in that junkyard. Somebody ought to talk to the parents of that kid and tell them not to play out there in the junkyard. Now the hospital can look and say, well, wait a minute. Let's try and keep Jason from getting cut on his leg anyway. So he's playing in a junkyard and he fell on some sharp, jagged steel. What if he was playing on a playground next to this apartment building instead of playing in the junkyard? What if we could get the city to build, make the junkyard more secure, clean it up, move it? What though if we worked with others in the community to build a playground next to the apartment building? Or maybe we just do a neighborhood revitalization and really work with the residents in here. One, to make sure they have health care. But secondly, to find out, are there ways that we can work and help get employed, and can we help mom get better? Or, way upstream, How can we help educate those vulnerable populations in our community to get more education, and then work in the community to find education and employment for these folks? So, hospitals are saying, they used to say, well, this is our job right here. So we'll let somebody else in the community. That's government's job or the health department's job on it. Now hospitals are saying, Jason's costing us a lot of money when he comes into the hospital. Or we've heard in focus groups that this, around the apartment building, that the parents are really worried about it. So the idea here is that hospitals really now can look at different ways of intervening. So when you start doing your community health needs assessment and decide on the scope, the question is, how far are you within the mindset, the thinking, your board attitude, the culture of the hospital? Where are you at this point in wanting to help address your clinical and financial goals and time with community benefit to reap good for the community and the organization? You know what the definition of community benefit used to be when I started? It's the fluff. It's those things we do in the community to make the community feel good about us. Or they would say, it's those things we do that we don't want finance to know about. Because if finance knows about it, they'll tell us to quit doing it. That was the definition of community benefit. So this is my last slide, and then I would like for us just to talk a little bit more about ways, or maybe some clinical indicators that you've got going on that might be better addressed in the public health arena. But CDC released this, and they were trying to say to healthcare providers, we're really big into counseling and education, but that has the smallest impact on overall health status in our community. If we go all the way down and address socioeconomic factors, poverty, education, housing, inequality, it has the largest impact on the community as a whole. And for hospitals, there are different ways now. We can do counseling and education. We can do clinical interventions, long-lasting protective. We can give immunizations. We can provide tobacco. We can do colonoscopies, which has greatly reduced the colon cancer. Or we can actually work in more of the public policy arena and do smoke-free laws, kind of the advocacy, tobacco tax. Do you know that the number one reason that kids don't start smoking or quit smoking is if you raise the tax because it's too expensive? I mean, that's what the evidence shows. We, have done programs in the past. I can remember doing some, and we talked to the kids about, showed them pictures of the lungs and stuff of smokers. They're invincible, didn't ring a bell with them. But if we said to them, a pack of cigarettes cost is going up. California did this, and they saw a tremendous decrease in the amount. Or it makes your breath smell and nobody will want to kiss you. Makes your clothes smell. They say, oh, well, think about that. But talking to them about health care and the traditional things we do makes no difference. So looking for those evidence-based programs, and then perhaps really addressing the poverty education and how far upstream can you go that way. Just one other example, and then I'll quit, but on the education part of it, there are hospitals that are actually helping vulnerable populations do small business startup. They're giving them some grants to do that, and one hospital helped I don't even think they had their green card, start a laundry, a commercial laundry in their community, which then the hospital now is purchasing that service from them, as well as other business and providers in the area. So they did that to beef up the education, the income, and at the same time providing more local-based jobs. So what other kind of jobs in the community that way? So
we've talked so much about the regulation, and I just felt like I had to talk about the mission. Because we are charitable organizations, and within Avera, our communities are really of utmost importance. And I really do attribute that to the Benedictine and Presentation Sisters, who they really laid that foundation for us, more than 100 years ago. And I'm always fascinated, and I'm sure Kayleen's heard this story many times, but how the sisters were called by community members and church leaders years and years ago. They were teachers, and they were actually called to, there was a diphtheria outbreak, and they were called upon to turn their schools and orphanages into hospitals. And I just think, gosh, can you imagine, you know, here you are a teacher and now you're being asked, but they responded to the community needs. And so our, you know, Avera's mission is to make a positive impact in the lives and health of persons and communities by providing quality services guided by Christian values. And I liked something that I pulled out of Sioux Center's CHNA, China. Anyway, they talked about, it said, although conducting CHNA is an IRS requirement, the awareness of need through data collection and collaboration with the community fits our mission to bring hope, health, and healing to life. The process provides direction for prioritizing our future strategies and developing community-driven goals that improve the health and wellness of the residents in our service area. And so I'm sure every hospital at this table, you know, you have your mission statement, and, you know, like we like to say, you know, I know that the regulation is new, but you've all been responding to community needs, you know, for years. But, you know, what's different is that now we have this very structured process that we have to abide by. So I thought I would kind of talk a little bit about our Avera's approach. What did we decide to do? And before, I'll kind of go back and forth, but Carrie, I'm going to pick on you. Recently, I went into CHA, had a meeting, and one of the questions they asked was, you know, what are the challenges out there? And so I threw that question out to my hospital community health needs assessment lead people. And I just thought Carrie's quote or comment, I thought it was just so fitting, not only for that CHA meeting, but for this meeting today. And she said that she would have to say starting the whole CHNA process over again was just, you know, a big challenge. I've heard many of you say, Dan and Kayleen, it's burdensome, it's, you know, it's overwhelming, it's big, it's, so anyway, that I think is kind of where Avera, so when the Affordable Care Act came out, and I think it was our leadership, and I think the Avera Rural Health Institute, which Kayleen is on the board, we recognized, we said, you know what, we think this is gonna be overwhelming for our hospitals. And so is there a role that the system needed to play in that? And we decided that, yes, you know, but we wanted it to be a measured approach. We didn't really want to dictate to them to say, you know, you're gonna hire this person, you're gonna do it this way. But we knew that there were a lot of resources out there, and was like, you know, is it very effective to have 30 hospitals all out there, you know, pulling census data and vital statistic reports and mortality rates and whatnot. So we created a SharePoint website. We did education. We actually had all of our administrators basically assign or appoint a point person, a CHNA point person, so that really kept our communication open, and we were in constant dialogue with them, which I think was helpful. We shared things. What I discovered is that many of our hospitals, they really liked templates or a model. It's like, well, what should a CHNA look like? What should my implementation look like? How many focus groups should I have? What's the makeup of those focus groups? And so we maybe had, you know, some hospitals that were just like, they were into focus groups, and they established, Avera Sacred Heart was one of our hospitals in Yankton. They were went out the chute early and, you know, had their focus groups, and we thought, gosh, why not share that? So we put, you know, how their focus groups looked out on our SharePoint site, and we shared that with our people to say, you know, not that you have to do it, but here's an idea, here's an example. So we established timelines and I didn't want to let anybody fall through the cracks, so I was kind of probably their irritant, but wanting their quarterly report, recognizing that things happen, life happens. So I would suggest like building in a little little room into your timelines. Carrie and her co-partner, Nancy, had babies and went on maternity leave. It's like, what do you mean? You've got a CHNA to do. You can't be having a baby. Yeah, exactly. So that was kind of our process. I thought I would just share some of the challenges, the common ones that I saw kind of across our system. And one of them I would say was just identifying and obtaining necessary skill sets. And I just think that your collaborative is it's going to help you so much, because really and truly collaboration does expand your community's capacity. And so think about, are there people within your community who have assessment experience and expertise? And I would hear that all across our region. This hospital would say, and they would be like, well, we know that she just came from, the Department of Health, and she facilitated focus groups. And so they knew they had that expertise, or I would hear somebody in the hospital say, gosh, I do not want to do a survey, but I love writing. I'd love to write the report. And so really looking at who are those people, maybe in your organizations, within your communities. I've got a couple of examples, a little town in northeastern South Dakota, Britain. They wanted to do focus groups. They didn't have the expertise. They didn't have a lot of money. And they hired a retired superintendent and a retired teacher to facilitate and report on their focus groups. They had a blast. They loved it. In fact, towards the end, they were like, are there any other hospitals kind of in the surrounding area that we could help? Because I think they felt useful, productive. They had the skills. They didn't even charge the hospital any money. In the end, I think the hospital paid them $50 each. So, thinking about, is there a university close by? We had a hospital that utilized students and instructors at DWU and Mitchell. So just really thinking outside the box and thinking about where those skills that maybe you don't have, but somebody would love to be a part of your collaborative. Val talked earlier about engaging the community, and I think a lot of hospitals found that very difficult too. So, how do you, the reg says, hey, you have to take into input, your broad community. Well, how do you get them involved? And we had hospitals that were like, gosh, we're sending them invitations, we've put it in the paper, and there's just no interest. And they were so frustrated. And so, I don't know why, but somebody at the hospital decided to pick up the phone and start calling. And they called, and on the other end was like, well, why are you doing this? And once the hospital explained that, one, they had to. I mean, they were required by law to do this community health needs assessment. They said that their community was like, well, we didn't know that. Of course we will help you. I mean, I'm guessing most of your communities, isn't your hospital pretty important to them? I mean, they wouldn't want to lose it. And so I'm just think of those ways that you can make sure you explain why you're doing it, that it's just not some random thing. Make a connection. Back to the obesity topic that you folks were talking about. We had a hospital that, they discovered everything, pointed to obesity, and that really the fruits and vegetables just weren't really available, although they did have a local grocer. And so eventually, the administrator realized it was like he really needed that local grocer, to help him with that. And I was just like, oh boy, but that was not a very, easy conversation to have. But in the end, he said the local grocer was just like, he worked with him, and they then worked with the SDSU extension to bring in a program at the local grocer. It was, I don't know, pick it, like it, try it, or something, where they, brought in certain produce, and you could try it, and there were recipes, and the hospital administrator was there, and the local grocer, and other, folks, and so that, kind of making that connection, making it relative to them, letting them know that you value their input and that you cannot do this alone. So that is how I think you engage your community. So if you're having a problem, maybe just step back. And how can you, if it's, senior, a lot of communities have aging populations. Maybe you need to kind of put it at that, like, how are we going to take care of, mom and dad? So make that connection with them so that they will help you. And I know, I remember the Hispanic population in Sioux County and some of the challenges with that. And so I think that was the last one is, don't overlook those priority populations. And like Dan said, that was maybe one of the, best focus groups that he had, but how do you connect with them? The next common challenge, I felt like a lot of our hospitals just kind of floundered with, was priority setting. And I think maybe part of that was because there isn't really one set way of doing it. And I think a lot of times people want you to just say, here, do it this way. And, they want templates, they want, just tell me how to do it. And CHA has a lot of guidance, and in fact, they provided, I can even pass this around, but it's like a priority, it's like a ranking sheet. And so you have your significant needs, and then it talks about the criteria, like how big of a problem is it? How many people does it impact? Could you really make an impact? And so you kind of go through that ranking, and you can just pass that around. And I think that helped so many of our hospitals. And so I think sometimes if you're just kind of struggling, to reach out, because there are so many great resources. And I know we sent that out to all of our hospitals, along with we kind of put together a document that kind of walked them through to like how to kind of focus on, like Patsy had said, that 3 to 5, like we tried to keep our hospitals really thinking 3 to 5, don't get any more than that, because really, how successful are you going to be? I mean, your resources are already scarce, so what's manageable? And then the last thing that, I guess the last challenge that I just wanted to talk a little bit about, and I think Patsy talked a lot about this all morning long, but just your CHNA report and describing the process. That was probably one of the biggest things I noticed with our hospitals. And so their report would come in, and they'd be like, what do you think? And of course, I'm the objective one, and I don't live in your community. And so it was easy for me to say, well, gosh, I see that you talk about your 9% Hispanic population, but I don't really see you talking much about that in your report. So did you conduct a focus group, or, and then if it was, or I don't really see you talking much about your uninsured or your most vulnerable, and then I would go back to Carrie, and then I think Carrie then she reached out to public health. And so I think you can't be afraid to tell your story. I mean, you're going to do a lot of work. And so I used to think, okay, I got to put on my Senator Grassley hat, and read this, and like, where would he punch holes in my report? And so I think that you have to think about that. It's also really nice, like if you have somebody within your organization, maybe that you can bounce things off of. I know in Carrie's situation, she had Nancy that was maybe more the editor, and so that was nice for her, because I heard people say, gosh, I feel like I'm back in school needing to write a paper and I can't remember how to do that, And so that was just, and then making the connections. Like I would see, they'd have all this stuff in their secondary data that would lead to, all these findings about obesity. County health rankings says Sioux County is, here, and then, the Department of Health says this, and then our focus groups, it would come up. But it was like not making the connections. And so I think that, as you're writing your report, anytime you can reinforce, it's like, so this is what the secondary data is saying, this is what the primary data is saying, this is what our ER data is saying. Had a couple of hospitals that I think they were maybe a little surprised by dental problems, and where they discovered it was in their ER departments. And so, that's probably something, not that the hospital could take care of themselves, but they could partner, with the Minnesota, it was Marshall, I can't remember who they partnered with, some mobile unit, so they bring in a dental mobile unit and supply the power so that people within that area could receive dental services. So making those connections.